All right, let's get going. This is Talk 4.5 on lymphoma. So, what is lymphoma? Well, it is a cancer of your lymphocytes, so B, T, sometimes NK cells, in which a solid tumor is formed, usually in the lymph nodes or the lymphatics, and sometimes extranodally. But let's get into this. So, if we think back to Unit 2 when we talked about leukemia, sometimes your lymphocytes there, or your lymphocyte progenitors rather, can cause some cancers. So, what's the difference there? Well, leukemia is more diffuse and it's more so a disease of the blood, of the marrow, whereas lymphoma is a disease of the lymph, and it's usually these discrete physical masses within the lymphatic tissue. Cell of origin, most of these arise from B cells, fewer T and NK cells. This is due to the repeated rounds of DNA rearrangement that the B cells undergo. Right? Remember the Thunderdome, the affinity maturation. Okay, that was including somatic hypermutation. I'll just do SMH for that. It was including also happening in the germinal center is class switching. So you have just a lot of stuff going on with the B cells, more so than you do with the T cells and with the NK cells. Thus, most of these malignancies arise from B cells. I think it's about 70%. So we can start in any lymphoid tissue, be it lymph nodes, your tonsils, thymus, spleen, and then I even have Peyer's patches. That translates to, right, any malt. Any malt. So tonsils as well. Any lymphoid tissue, any place where these cells, these lymphocytes are present, you do run the risk of potentially creating a malignant one. We have two major categories: Hodgkin's lymphoma and non-Hodgkin lymphoma. Hodgkin lymphoma is literally defined by the presence of Reed-Sternberg cells. These are abnormally large lymphoid cells, and they have more of a predictable, continuous spread. Ignoring drainage pathways, but following anatomy. Non-Hodgkin lymphoma can skip nodes, a bit more haphazard, more diffuse, appear more often extranodally, and are more of a basket of different lymphoid cancers. So more of a general term. Big thing though, this is the defining feature, Hodgkin versus non-Hodgkin. You have these large eosinophilic, meaning pink staining, multinucleated, meaning multiple nuclei. And just like almost what is that? That's a regular lymph node or lymphocyte, so a good 10 to 20 times larger than the regular cells. So that is the big Reed-Sternberg cell, the RS cell. That is the defining characteristic of Hodgkin's lymphoma, which allows for us to see a more discrete, traceable path than opposed to the more diffuse non-Hodgkin's lymphoma. Okay. So this is just giving you an overview. It can develop almost anywhere lymphatic, and then we have a mass forming within the lymph node. Doesn't have to be a lymph node, but that's a common occurrence for sure. So let's talk more about the Hodgkin's lymphoma type. Again, Reed-Sternberg cells, abnormally large, multinucleated, eosinophilic, sometimes referred to as having an owl eye appearance because the multinucleated cells look like owl eyes. I don't know, maybe a little creative on that front. I'm not a pathologist. I haven't seen them under the microscope, but maybe they have that look. This does have a higher survival rate than most of the diseases that we've discussed, about 90%. So that's pretty good. Most of the stuff we discuss is pretty morbid, so it's nice to see that. Common in Caucasian men. Those were the two groups that I saw. Most common in men, most common in Caucasians. So Caucasian men. All right. Typically starts in cervical lymph nodes. Where are those? the cervical region, think cervical vertebrae, cervical spine, that's my neck. My neck. So a patient might present with a big old lump coming off their neck. All right, usually localized to that area and painless. These masses usually don't have pain associated with them. The clinical pearl is if it's painless. A painless mass is usually a cancer malignancy. A painful mass is usually infection. Again, all my patients are dead. I'm an anatomist, so I don't know what I'm talking about. But that is what I've heard. Bulging and a rubbery kind of consistency to it. I've also heard stories of pathologists being able to tell just that's Hodgkin's lymphoma just by the touch or by the rebound of it. So that's kind of cool. All right. And also remembering that some of these viruses that we've discussed do give you an increased incidence, an increased risk of cancer, because these viruses mutate these long-lasting cells that are supposed to provide us defense, which can eventually, lead to them becoming cancerous if that mutation persists and starts to mess with the normal cell cycle. So HIV patients are at higher risk because their CD4 T cell count is knocked out. So we have depleted cell-mediated immunity. If I don't have my CD4 T cells, then I can't accurately inform my CD8 T cells what to do. So my viral defense is immensely diminished. And not to mention my cancer defense is immensely diminished because the CD8 T cells also recognize when something intracellular is going wrong. So that's usually viral infection, or it can be oncogenesis, tumor creation. And the same thing with EBV. Right? This is a virus that hides away in your memory B cells, and it can cause the condition known as mononucleosis. What did that cause? Well, that's abnormal-looking lymphocytes, abnormal B and T cells, due to them trying to fight off this pervasive, persistent infection of EBV. If replication keeps occurring and potentially goes wrong, well, then we're at a higher risk for a oncogenic mutation, a mutation causing a disruption of the cell cycle and unregulated replication. Yeah, so those viruses are really nasty because of that. Let's take a moment to discuss Ann Arbor staging. I have this in the Hodgkin's lymphoma section, but I've also seen it characterized in non-Hodgkin's. I guess it just depends on the textbook you're reading. So, Ann Arbor staging, we can break it up into 4 stages. Stage 1, single node region. So that's just a lump on the neck, and that's all she wrote. Stage 2 can be multiple regions on the same side of the diaphragm. So are we all north or are we all south? Okay, that's important. The diaphragm, it separates your thorax from the abdomen. So if we are on both sides of that meridian, that means we are really flowing through the blood and the lymph. If we're contained on one side, then that's a sign that maybe it's not as metastasizing as rapidly as it would be if it was on both sides of the diaphragm. Stage 3, it is on both sides of the diaphragm, so we're getting rapid, diffuse spread. Stage 4, disseminated, and usually means extranodal infection. So something not infection, but let's go spread. That makes more sense. So something that's not part of the lymphatics. Okay? That means not only am I getting diffuse spread in my lymphatic tree, but now it's spread so much that it's going to the blood and getting into an organ space or an organ tissue or connective tissue, what have you. Another layer to this is that we can say they are A or B. Sometimes the patient has absolutely no symptoms, apart from the painless swelling, they just have no other symptoms. That would be characterized as A. If they're B, they have fever, sweats, weight loss, one of the three, two of the three, or all of the three. That is what we call a constitutional symptom. So if that's present, then they are type B. So, down to the chart here. Stage 1, one mass, one malignancy, and that's all she wrote. Multiple malignancies in stage 2, but all north or all south of the diaphragm. Stage 3, multiple malignancies north and south. And then stage 4 is just we are everywhere. And in this diagram, we don't have it, but it'd be infecting something, not infecting, it would be spreading into something that is not inherently lymphatic. It is extranodal. Okay? So, somebody with 2 masses, or 3 masses, multiple masses, rather. Okay, calm down. Multiple masses on one side of the diaphragm, that person would be stage 2. Okay? And then if that person is also experiencing a high fever, weight loss, sweats, they'd be 2B. Right? If this person has masses on both sides of the diaphragm, but they're not experiencing fever, weight loss, or sweats or anything like that, then they'd be 3A. So that's just how that staging works. Where's the spread? How bad is it? And do you have constitutional symptoms associated? That's it. And then just to cap it off with non-Hodgkin's, all right? So this is much more present than HL, than Hodgkin's lymphoma. And the big definition here is just we don't have any of those Reed-Sternberg cells present. None of those RS cells are there to, I guess, localize this site of oncogenesis. Symptoms, there's some constitutional symptoms, so that fever, weight loss, sweats, hepatosplenomegaly, so the spleen gets bigger because it's trying to fight off this diffuse spread of cancerous, of oncogenic cells. And same with the liver. We get diffuse spread to that organ. We're trying to maybe detoxify. And it's just not happening. So we get that extranodal spread. The liver is detoxifying all of the gut blood. So eventually that organ gets recruited into this nastiness as well. That causes inflammation, and we get enlargement of those organs. Adenopathy, same kind of deal. That is lymph node swelling. So if this malignancy, if these oncogenic cells travel towards whatever lymph node they are near, the B and T cells in that area are going to try and stop that cancer. So you're going to get a lot of replication. Like whenever you're sick, you can kind of feel the nodes underneath your jaw, or maybe the nodes in your neck. Those get big, those flare up. Just imagine that times 10, because you have a diffuse cancer going on. Okay, and they can be B or T cell mediated, but yes, usually 70% of these are going to be B cell mediated just because of the many, many rounds of genetic mutation that these cells undergo. Remember, they can go bounce between the dark and light zone many, many, many times to get the best antibody possible. So if that process goes wrong, who knows what kind of cell we can produce. More so for non-Hodgkin's lymphoma, we have extranodal involvement. So it's more diffuse. We don't have this heartbeat, this central cell that we do have in Hodgkin's lymphoma. And again, the viruses that we've been discussing from last unit, they really can disrupt correct replication and correct cell division, leading to an increased incidence of these cancers. So EBV, HIV, we haven't talked about yet. Human herpes virus 8, and oh my gosh, I forget the name of this one. I think it's human T cell. Oh man. Human T cell something. Very similar route that HIV takes, in which it targets our CD4 cells. So that same kind of deal. We have diminished defenses, and not to exaggerate or be morbid, but cancer is happening all the time in healthy individuals. It is a side effect of biology. We have to do constant cell replication, and that includes constant mutations. Odds are you're going to knock out a gene that suppresses cancer, that suppresses tumorigenesis. We have defenses in place for that. We have the cells that these viruses knock out, our CD4 T cells. They communicate to our CD8 T cells to regulate any improper presenting cells. So if those are gone, if my defenders are gone, you have an increased incidence, an increased risk of cancer. So it's helpful, obviously, when we do not have that infection. Then our cells they can do what they're built to do. The CD8 T cell, not only does it combat viruses, but it combats tumorigenesis. So odds are, at some point in your life, some tumorigenesis will occur, but your immune system will handle it. So that's why it is so damning when these viruses can mess with the coding of those defenses. So, yeah, very cool to think about. But yeah, that is our lymphoma talk, and thank you guys for your continued attention. Sorry, started rambling a little bit there, but it happens. It happens. All right, adios.